Good morning. Welcome to the first segment of Fertility Speak Conversations with Experts. I'm Dr. Daniel Stein, a senior partner of Reproductive Medicine Associates of New York, one of the nation's premier and most respected fertility practices. I have over 27 years of experience as a reproductive endocrinologist, fertility specialist in New York City, and my partners, associates, and myself have helped thousands of couples to achieve parenthood. Over the next year, I will be hosting a series of discussions with experts at RMA of New York and other centers on multiple topics regarding infertility. Today, I am both pleased and honored to present Dr. Beth McAvey, Medical Director of RMA of Long Island, and consistently named one of the top doctors in New York. This segment of Fertility Speak is called Infertility: How Common Is It and What Causes It? Welcome, Dr. McAvey. Thank you for coming today.
Thank you so much for having me. This is great. I'm really happy to be a part of this and to share, our knowledge for patients. So thank you for having me.
So Dr. McAvey, it's estimated that each year, approximately 1 in 7 reproductive age women and couples in the United States seek treatment for infertility. This number is probably an underestimate because many of these statistics do not include same-sex male and female couples who are trying to conceive. Obviously, infertility is a very significant issue with really tremendous implications for family building, for personal well-being, for even the future workforce and economic development. So this term infertility is used very generally and widely. What is infertility? How would you define it?
So, to your point, we have to look at the patient that's presenting. So for a male-female couple that is presenting, infertility is defined as inability to conceive over a certain duration of time. So historically, we would say 12 months of regular unprotected intercourse without a conception, without a positive pregnancy test defines infertility. Age is clearly a very big predictor of the ability to conceive. So as patients get older, we believe that the 12-month duration should likely be shortened. So over 35, most of us would agree that if no pregnancy happens after 6 months of unprotected regular intercourse, that would be a reason to see an infertility doctor and have an evaluation for infertility. To your point, though, not everyone presents in a male-female couple. And so, that definition is not black and white. We have to think a little bit outside of the box. And we struggle a little bit with that. For instance, with same-sex female couples, as they present, they haven't had exposure to sperm.
Right.
So, are they infertile? We sort of put them through this process of evaluation, but it definitely needs to be thought of a little bit differently for same-sex female couples, and then obviously for same-sex male couples.
Well, you raise actually a very good point because in keeping with our times and in fairness to the whole population, the American Society for Reproductive Medicine recently changed its definition of infertility to really include all couples who are not able to conceive over that specific time frame. How common really is this? Because yes, we know what defines it, but if you're a couple just starting out trying to get pregnant, when could you expect to get pregnant, and when do you start to get worried?
So again, I typically would counsel patients. It's if it's a male-female couple, it's based on age. Every patient has a different thought process going forward. When patients decide, let me try to get pregnant, if it doesn't happen after a few months, sometimes, they become worried, and it's really our job to say, okay, you're 30 years old, everything looks good, continue along the course of trying, and, before we make a plan to go forward for treatment. But it is age-based.
Can that couple expect to be pregnant in a year? And what percentage of them will be pregnant if it's, let's say, a heterosexual couple? What percentage of those can expect to be pregnant within a year, and what percentages wouldn't be?
Around 85% of patients will be pregnant within 12 months of attempting conception. up to 15% of, patients would not be. So, but to your
Okay.
point, it may be more than that, but I would say that's a good general, estimate.
Okay, great. No, that's helpful. And you mentioned, obviously age is a very important factor, and we'll go a little bit more into that as we continue. What about racial differences? Do you find there are differences between different races or ethnic groups with regard to getting pregnant and time it takes to get pregnant, or even just the risk of developing infertility?
Right. I think it is well understood that there are racial differences in terms of ability to conceive. Specifically looking at Black and non-white Hispanic women, the rates of infertility are higher. It might be due to several factors. And there's also the ability to access care, which is, a very broad and, large topic that we discuss, frequently, in our field, I think for all fields of medicine. But, taking away the access to care concern, yes, I believe there are racial differences. We know that Black and, non-white Hispanic women do have, slightly higher rates of infertility in comparison to white patients.
It's interesting. There have been a lot of studies, and some of the studies haven't been great because they've been controlled for a lot of factors.
Right.
But of particular interest, there was one study that not very long ago, which did show a twofold increase in the prevalence of infertility among African American women,
Right.
even after controlling for socioeconomic factors, access to care, ovarian volume, a variety of different hormonal factors. So we don't even know yet. I think we've just really touched the surface and trying to understand why there are racial differences. In several weeks from now, in one of our segments that will be coming up, we'll be speaking with Dr. Tia Jackson-Bay, who is one of our reproductive endocrinologists associates in Brooklyn at RMA of New York in Brooklyn, and we'll be able to go a little bit more into depth on this.
I think it's a topic that is, close to her heart, and she's a large advocate, for that. So
absolutely. So let's talk a little bit more about the causes of infertility. Next in our next segment, I'll be speaking with Dr. Rachel Gerber of RMA of New York and Westchester, who will be discussing the specific diagnostic evaluation. But let's talk just more generally about causes. And I know, both of us have been doing this for a long time. And there's a variety of different factors. So let's start with one of the biggest factors, which is really ovulation disorders, which can account for, up to a quarter of cases of infertility. How does somebody know if they're ovulating?
right. So generally, when a patient presents, one of the first questions that we ask is, do you get a menstrual period? Very simple question. Not that it always means that somebody has ovulated, but if a patient is reporting that they are getting a menses monthly, regularly, like clockwork, every 28 to 30 days, odds are they are likely ovulating. Patients who present and say, my cycle pattern is extremely irregular. Sometimes I'm every 40 days. Sometimes I'll skip a menses, every 2 to 3 months. I haven't had a period in 6 months. That very much tells us the patient is not ovulating. And again, there are some in between that we're not exactly sure, but in general, we start with the clinical question, do you get a regular period? So that is, I think both of us would agree, we warn patients on using, let's say, ovulation predictor kits or apps on their phones, which everyone is using today, to really try to figure out, are they ovulating, yes or no? There are, it's sometimes those tools are not actually telling the real story.
So how does one know if, how does a woman know if she really is ovulating? Because we both know that the only true proof of ovulation is if somebody conceives naturally. But what kind of tests do you tell people to do to give you a better understanding, and to give them a better understanding of whether they truly are ovulating?
I mean, personally, for me, cycle pattern history is the most relevant. So, in today's day, most patients are using apps where they're able to chart their cycle pattern. And in somebody that's getting a period, on the 1st of every month or the 10th of every month, odds are they're ovulating. There are patients that use ovulation predictor kits, which can detect luteinizing hormone. Luteinizing hormone, elevates at time of ovulation. So again, in a patient who's presenting with a regular cycle and they have an LH surge on an ovulation predictor kit somewhere at mid-cycle, odds are that they're ovulating. But it is very important to realize that those kits are not perfectly accurate. And in someone that has an ovulation disorder at baseline can often get false reads on the ovulation predictor kit. But I really think it's clinical presentation. Do they get a regular period every month?
Absolutely. We know that polycystic ovaries, thyroid disorders, those increases in the production of prolactin, which is a pituitary hormone, can cause people to not ovulate. Even people who have what we call hypogonadotropic hypogonadism, which basically the brain isn't stimulating the ovaries properly, particularly long-distance runners or excessive athletes, or people with eating disorders. So we know who's at risk of this. So ovulation disorders for sure are a major source of infertility. How about fallopian?
Underweighted. We also, in dealing with obesity, certain medications, might, like psychiatric medications may. So diabetes, other metabolic conditions. We really look at the whole patient when they present and take that history and to see what's happening.
That's an excellent point. We, sometimes we might forget about the medication, so we do get a very detailed medication history. But that's a great point. Fallopian tube disorders, also very common. People who have blockages in their fallopian tubes. Why might somebody actually have blockages in their fallopian tubes?
The most common reason for blocked fallopian tubes likely is an exposure to an infectious, agent at some point in their prior life. So pelvic inflammatory disease, an exposure to chlamydia at some point has a fairly high rate. I believe some of the studies quote even 20% of having a tubal blockage after one exposure to chlamydia. And, exposure to that bacteria is typically not known. Often the patient, presents without symptoms and we discover it during an infertility evaluation. So some, sexually transmitted disease, chlamydia, pelvic inflammatory disease, anyone that's had a prior abdominal pelvic surgery, so bowel surgery, a ruptured appendix, very common, right? Those are things that we think about, to evaluate for tubal patency or opening of tubes. Fibroids, so uterine fibroids are extremely common, especially in Black and Hispanic patients. I think up to 50% of certain racial groups can have uterine fibroids. And if they're quite large, that can cause, internal sort of closure of the tubes.
Absolutely. These are all very common things. And let's not forget endometriosis. Endometriosis as well.
Yeah, that's also, we see a fair amount of those patients in the office. Endometriosis can cause scarring on the outside of the fallopian tube. And so, yes, all of those causes need to be ruled out and evaluated for patient, especially if they're presenting with tubal factor.
Great. Male factor. Okay. Obviously, one of the things is, and there's still this sort of this feeling among many couples, and interestingly, a lot among women as well as men, that this is a female problem, when we know, in fact, that's not really always true. It's not even close to true. There's a very significant proportion of cases of infertility that are due to male factor. And we're going to be speaking in a few segments from now with Dr. Natan Brahma, who is the former chief of reproductive urology at the Mount Sinai Health System, and also the reproductive urologist at RMA of New York, about male factor in more detail. Right. But when you have the partner get a semen analysis, what are the things that you're really looking for? Not so specifically, but sort of the general things that you look for.
I mean, we're looking for evidence of sperm production, so looking at sperm count, looking at the percentage of sperm that are motile, and then we're looking at how the sperm look under the microscope, which is called morphology, and I'm sure Dr. Bahama will go into more detail on that. But even just basic question up front, is there sperm production? Yes or no. So, I agree with you. We see a very large percentage of couples who present where there is an abnormal semen analysis or an abnormal parameter on the semen analysis. So, yeah, I mean, it's, whether or not there's sperm production, and then how does the sperm look, and are the sperm motile? Are they moving forward where they can swim and attempt to get to an egg? I'm in a natural setting.
So exactly. So a good amount of moving sperm. And we do look at the shape, obviously the morphology of sperm, which may have some effect in the ability naturally of that sperm to penetrate the egg. But yes, I agree with you. Those are the most important things. Getting it down to a nutshell, you're exactly right. Is we just want to know that there is sperm, that they're moving, and that they're there in a good amount. And when we discuss with Dr. Bahama, we'll go over some of the various biological causes for male factor, including even genetic abnormalities. Let's skip to uterine factors. You mentioned fibroids before as potentially affecting the fallopian tubes. They can obviously affect the uterus. What other uterine factors besides fibroids might you think about as potential causes for infertility?
So I would say fibroids is number one, in terms of prevalence. We see a lot of, which is it's a tough presentation, but we see a fair amount of adenomyosis, is essentially endometriosis that has entered the uterine wall, in sort of layman's terms. But it is a uterine condition where patients present with very heavy menstrual bleeding due to a thickened uterus. So the uterus typically presents bulky, is how we describe it, larger. And for those patients, there are higher rates of infertility and higher rates of miscarriage. When we're evaluating patients, we're actually able to see it on ultrasound. There are other imaging modalities that exist, like an MRI, but adenomyosis is something that is significant and sometimes challenging to treat.
And I just to give a little further edification, so you mentioned sort of like endometriosis in the uterine wall and the muscle wall of the uterus, which is exactly right. But for those out there who are not as familiar with the term endometriosis, can you describe what endometriosis is?
Endometriosis is a clinical condition where endometrial cells leave the actual structure of the lining of the uterus and go other places. So if it goes into the uterine wall, it's known as adenomyosis, but it can go to the fallopian tubes and cause tubal factor. It can be in the ovary and presents as endometriotic cysts, known as endometriomas. Sometimes patients might refer to them as chocolate cysts. The endometriosis can go into the pelvic wall, into the side wall of the pelvis. It can travel into the lungs, into the liver. I mean, there's other places it can go, but typically does affect the pelvic region primarily and can lead to infertility.
Great, yes. We will have a segment specifically about endometriosis and endometriosis surgery coming up over the next few months, so we'll be able to go into more detail. What about congenital abnormalities? Not everybody is born with the picture-perfect uterus.
Right. So, sometimes along development, there is, an aberration in how the uterus is created and how it's made. It's interesting, sometimes patients are these are incidental findings on ultrasound and the patient isn't actually infertile. We know that certain congenital uterine anomalies are very much linked to recurrent miscarriage, which I suspect is, a different part of your YouTube series. But So it
Absolutely.
is part of our evaluation, whether it causes infertility up front, I think the jury is out. But it is something that we have to take into account when we see a patient who's presenting with infertility. Is there something that we want to address or do on a patient who has a congenital uterine anomaly, up front? There are some congenital uterine anomalies there's nothing to do, a unicornuate uterus, for instance, which is sort of the presence of half of, a uterine cavity. It's how somebody was born. There's absolutely nothing to do about it. And there's a very large percentage of those patients go on and have successful live birth. Same for something called a didelphys uterus. Those patients, there's typically nothing to do, and they go forward and they are able to have successful live births.
And those are the ones, those are patients who actually have two separate uteri,
That's correct.
right?
The one congenital anomaly that is always a discussion point is the presence of uterine septums.
Right.
And that is sort of where it's not a full divide of the cavity, but there's, a half divide of the cavity. And sometimes there is a recommendation made to do a resection, of that uterine septum. But it is, so that's a discussion definitely to be had with one of the physicians.
Absolutely. Yeah, and we certainly will go through that. The uterine septum, I always explain to patients, it's like taking a studio apartment and then putting up a wall to make it a one bedroom. And it doesn't work so well.
Depends on the size of the septum, how large is it, all those decisions to be made,
Absolutely, absolutely. Let's go to just we know that probably 15% of cases of infertility, we're not going to find the cause in our basic evaluation.
Yeah.
And it doesn't mean, of course, that there's no cause. There's always a cause, but we haven't been able to identify it yet. Do you see a lot of unexplained infertility?
Yes.
And generally, I won't talk to you today about treatment, but what are the things that you tell patients when it comes to unexplained infertility? Because they may be really puzzled and say, well, if you don't know why I'm not getting pregnant, what can we even do about it? What should we think about?
Right. So, the definition of unexplained infertility is, exactly what you said. Everything looks good on paper. The sperm analysis is normal. The fallopian tubes are opened. The ovaries look appropriate for age. The uterine cavity looks healthy. The uterus looks healthy. And it's essentially unknown or unexplained. I believe if we left the patients alone and let's say they just tried to conceive ongoing, there's probably a percentage of them that will end up getting pregnant. But, again, as our patient population is aging, we are all seeing patients who typically are older at initial presentation. And, it very well could be that the unexplained is some sort of egg factor at baseline, or perhaps a sperm factor, things that are not testable. What I mean by that is quality of egg or quality of sperm. Perhaps
Right.
that is really what unexplained infertility is. And it's not really measured. So, I agree. For patients that present with unexplained infertility, if it's 12 months, most of us are going to very much, suggest that they do go into a fertility treatment. What that treatment is, to be determined. But if it's been 12 months and everything does look okay on paper, likely those patients still will go into a fertility treatment.
Yeah, no, I agree. Look, if somebody comes in, at 30 years old, if a couple comes in at 30 years old and they've been trying for a year and haven't gotten pregnant and everything, as you said, looks good on paper, well, you could certainly be a little bit more liberal in time and having them continue to try if they wish to do so. Absolutely. But I agree with you 100%. As patients get older, and particularly those over 35, time is of the essence. And sure, some of them will get pregnant by continuing to try above a year, but many will not, and we lose time.
Yes.
So, what I want to do, finish off today really is talk about one last thing, and that's what we call ovarian reserve testing. And I'll be speaking over the coming weeks with Dr. Phil Romansky about ovarian aging. But let's talk just a little bit about, how do you tell patients, or what do you do to assess what somebody's ovarian aging looks like? Because we're very concerned about the loss of eggs and the increased rate of chromosomally abnormal eggs as women get older.
Right.
So how do you do ovarian reserve testing?
So ovarian reserve testing is done typically twofold: ultrasound evaluation of the ovaries and then blood work. So the ultrasound evaluation is looking at something called the antral follicle count. So follicles are structures that are in our, are in the ovary, and essentially represents egg quantity. To your point, as patients are getting older, we know that there's a natural process of losing eggs, on a monthly basis. And so, as females age and they hit their reproductive span, and as they age, the egg count goes down every month. So we have age-specific averages of what we know a normal antral follicle count should look like. And so age of the patient at time of evaluation is very important before we say your antral follicle count is normal or not. And so that's, ultrasound evaluation, just looking at egg quantity. And then the blood work that goes along with that is a blood test called anti-Müllerian hormone. It's otherwise known as AMH level, which is a blood test that can be sent at any time in the menstrual cycle. And again, correlates with egg quantity.
Right, not necessarily with the chance of getting pregnant over that next 6 months, but
And
you're right.
quality. There's really no test for egg quality. I'm sure you get that question often. Are my eggs good? There really is no test unless they are to go into a fertility treatment that allows us to test embryos that are created from eggs. But a quantity assessment, I think, is helpful for couples when, for a patient when they come in. So look at count on ultrasound and then send an AMH level.
Yes, great points. I always caution OBGYNs who I speak with, because we work with many wonderful OBGYNs, but they're oftentimes a little bit confused about what to make of AMH levels and how to counsel patients about that. And that's reasonable, because there are some controversies with regard to understanding AMH, but we don't want to tell a 38-year-old woman that because her AMH is good, that she has a decent number of follicles in her ovaries, that she can keep trying if she's been trying for the last year and hasn't gotten pregnant, because AMH has limitations. It doesn't tell us about egg quality. It tells us much more about quantity. And we don't want to use that information to tell people, hey, your AMH is good, so there's really no problem. And then vice versa, we don't want to say if the AMH is poor, you're not going to get pregnant. That also wouldn't be true.
I think it's helpful, let's say for a single female who goes, presents to the general OBGYN, they send the AMH and it's low. And that patient is not planning to get pregnant, for the next 1 or 2 or 3 or 4 years. Those patients likely should egg freeze, should egg freeze. I believe our recommendation would be to do that. Just if we see a lower AMH, it gives a reason to say, okay, we're a little concerned about this. Yes, you're not an infertile female, but we know that it's lower at this point. You're not planning to get pregnant in the next few years. Maybe we should consider egg freezing.
Right. No, excellent. Well, these are excellent points. And I think this is a very good sort of intro understanding for patients of what infertility is and what are we thinking about as potential causes. This really concludes this segment of Fertility Speak Conversations with Experts. Again, I'm very happy and grateful that you were able to come on today and do this interview with us and to educate patients. And then in our next session, we'll speak with Dr. Rachel Gerber, who will go in more detail into the actual diagnostic testing that we do at that first visit. But thank you so much, Dr. McAvey. I really appreciate it.
Thank you for having me.